Assalamualaikum and good morning, everyone. First and foremost, I would like to thank all of you for joining us for today's CME. So I'm very and extremely honored to be the moderator. We have two great people today. So I'm going to start off with introducing to all of you our first speaker of the day. She is Dr. Gaik. She's a consultant neurologist in the neurology department of Penang General Hospital. She graduated in 1998. I just finished my SPM during that time and obtained her MRCP in June 2001. So she completed her postgraduate training in neurology in 2005 and further subspecialized in epilepsy in Cleveland Clinic Foundation, USA in 2006. So she has passion in teaching and wide interest in various fields of neurology, neurophysiology, neuropsychiatry, and neuro-ophthalmology. She has published a lot of books, and the one that I'm holding now is one of her book. I'm one of your fan actually, and most of us who has experience of using Sarawak General Handbook during a housemanship, she's one of the author as well. So apart from that, another striking, interesting background of her is she's a bronze medalist for Tournament of Mind during the World Congress of Neurology in 2019. So we are very proud to have her around. Thank you very much, Dr. Yo, for spending a bit of your time to teach us about below the belt neurology. So Dr. Yo, the floor is all yours.
A very good morning to all of you. Thank you to Dr. Nina Nasrina for the kind introduction. December is a holiday month. I would like to take the opportunity to wish all of you a Merry Christmas and Happy New Year. And let's make this session as interactive as possible. You can type in the questions in the chat box and we will answer it during the Q&A session. Before I start, may I ask any one of you have seen patients or with incontinence or have relative with dementia or incontinence? You can type in the chat box 1. And today the subtopic that I will cover include what is meant by below the belt neurology, what is urinary incontinence, what is neurogenic bladder, who are affected, patients who are multiparous, patients with BPH, patients with neurological conditions like spinal cord injury, head injury, or epilepsy, when it can occur, where is the pathology, where is the micturition center, and why this patient develop urinary and bowel incontinence, and what is the psychological basis? How do we investigate and how do we manage? So below the belt neurology actually include 3 organs that is found below our belt. That includes bladder, uterus, the sexual organ, and the bowel. So it can be either urinary retention or incontinence, constipation or fecal incontinence, and sexual dysfunction. I will also cover the type of incontinence and the underlying causes, physiology of micturations, type of neurogenic bladder, spastic or flaccid, and approach to urinary incontinence, the algorithm, and case examples. So anatomy of the bladder and lower urinary tract includes 3 main components: bladder, internal urethral sphincter, and external urethral sphincter. So in general, man has a higher capacity and the bladder consists of smooth muscle. We call it detrusor. And there is a trigone, which is sensitive. So when a patient with BPH, when he lie down, because of the urethral prostate enlargement with bladder obstruction, bladder outlet obstruction, this residual urine will stimulate the trigone, leading to urgency and nocturia. Internal urethral sphincter is a smooth muscle innervated by autonomic nervous system. Upon parasympathetic stimulation, the bladder will contract and the internal urethral sphincter will relax. If the social situation is correct, that means we are already in the toilet, then the external urethral sphincter will be relaxed by our voluntary control via the pudendal nerve. So this slide summarizes our brain will act as a control, and the micturition center is in the pons, dorsal pons. So autonomic nervous system, sympathetic and parasympathetic, will innervate the bladder. When the bladder is full, we will feel the urge to pass urine. So conditions like patients with epilepsy, during the fit, they can have urinary and fecal incontinence, especially in the grand mal seizure, generalized tonic-clonic fits. Other neurological conditions like multiple sclerosis, Parkinson's disease, multiple system atrophy, dementia, normal pressure hydrocephalus, fronto-temporal dementia, and brain tumor also can present with urinary incontinence. Spinal cord injury or TB, transverse myelitis, MS that involve the spinal cord, either conus medullaris or cauda eguina, may also present with incontinence, urinary or fecal incontinence. Conditions that affect our autonomic nervous system also can cause incontinence. For example, GBS. Okay, so this slide summarizes the CNS and innervation of the bladder. Upon stimulation, the pontine micturition center will stimulate the parasympathetic and cause the detrusor muscle to contract and urethral sphincter to relax. This is a very important slide. This is a very important slide. So we have a spastic bladder or flaccid bladder and detrusor dyssynergia. So if the lesion is above the pons, we can have overactive bladder and normal sphincter. So so mainly because there is an overactive bladder, keep on contracting, so we will have, patient will have storage symptoms. Whereas infrapontine suprasacral, that means if the lesion is below the pontine, below the pons and above the sacral outflow, it will involve thoracic sympathetic outflow. So patient can have both storage and voiding problems. Why? Because there is overactive bladder, at the same time, there is also overactive sphincter. So when the bladder contract, but the sphincter doesn't relax, the sphincter is in the overactive state. So it causes both storage as well as the voiding problem. The patient have hesitancy, they cannot initiate, and that leads to urinary retention. And when the intravesical pressure exceeds the pressure that the internal sphincter can hold, then there will be incontinence, overflow incontinence. So sacral outflow involve the parasympathetic outflow. So patients have flaccid bladder. The bladder is underactive, cannot contract. And sphincter can be either in a normal state or underactive state. So patient also will have overflow incontinence. So you need to have suprapubic compression to release, or using the intermittent self-catheterization, or continuous bladder drainage using the CBD. So there are 5 main types of incontinence. Stress incontinence. Urine leaks when there is increase in intra-abdominal pressure following the cough, sneeze, or laughing, or holding or lifting something heavy. Urge incontinence often happen among patients with benign prostatic hyperplasia when they have associated prostatitis and UTI. Overflow incontinence is a type of neurogenic bladder where the patient cannot initiate, leading to urinary retention that exceeds the pressure that the internal sphincter can hold. Functional incontinence and mixed incontinence. By far, the most common two types of incontinence include stress incontinence and urge incontinence. And some patients may have mixed. So this slide is a very important slide that explains the under normal condition, upon parasympathetic stimulation, the bladder will contract and the internal urethral sphincter will relax. When there is a pelvic muscle weakness following like vaginal hysterectomy or multiparous obstructed labor, or male patient who had undergone prostate surgery like TURP, TURBT, transurethral prostate removal, they may have urethral injury. So there is weakness of the urethra leading to stress incontinence. That means the urine leaks out when there is an increased intra-abdominal pressure, leading to increase in intravesical pressure. So urge incontinence happens when there is infection of the bladder. The trigone is very sensitive and they can cause overactive bladder. So patient has the urge to pass urine. And this happens especially when the patient lie down, because trigone is actually at the dorsal part of the bladder. Overflow incontinence happens when there is bladder outflow obstruction, or there is neurogenic bladder leading to flaccid bladder. So what is meant by neurogenic bladder? Neurogenic bladder is defined as lower urinary tract symptoms occurring following neurologic disease. It can be epilepsy, it can be spinal bifida with myelomeningocele. Patients also will have neurogenic bladder. So always try to rule out UTI that causes the incontinence. So this slide summarizes sympathetic actually causes detrusor muscle relax so it can hold the urine, internal sphincter contraction. Parasympathetic stimulation will cause detrusor contraction and internal sphincter relaxation during voiding. And voluntary control via the somatic pudendal nerve will only initiate the micturition when the social circumstances is correct. So in patients with dementia, they lost this voluntary control, so they can micturate when there is a inappropriate social situation. Patients with fronto-temporal dementia also attribute this problem. So storage problem mainly is urgency, nocturial frequency. Volume problem include hesitancy, straining, retention, interrupted flow, terminal dribbling. So what is meant by detrusor sphincter dyssynergia? There is incoordination between the detrusor and sphincter. Under normal condition, when the detrusor muscle contract upon stimulation of parasympathetic activity, when we want to initiate the micturition, the sphincter, the internal sphincter should relax. But if both also contract, that can cause raised pressure because there will be built-up pressure within the bladder. And that can cause backflow, leading to hydroureter and hydronephrosis. So sometimes we need to order ultrasound for patients with BPH to see whether there is prostate enlargement with complications like hydroureter and hydronephrosis. And patients with ovarian malignancy, cervical CA malignancy, sometimes they also can have this backflow problem due to compression of the bladder. So lower urinary tract symptoms in MS is common actually, and the incidence or the prevalence actually increase as the disease progresses. And patients with MS, they actually present with both storage and voiding problems. And there are detrusor overactivity and detrusor sphincter dyssynergia. So just now, I actually explained about infraspinal, infrapontine supraspinal lesion leads to detrusor sphincter dyssynergia. So cerebral lesions in the frontal lobe may, or pons may also result in loss of voluntary control. So what about lower urinary tract symptoms in PD? It is actually also very common. And for patients with Parkinson's disease, storage symptoms are more common than the voiding symptoms. And nocturia is one of the most common non-motor symptoms apart from REM sleep behavior disorder and constipation. Both overactive bladder and nocturnal polyuria contribute to the nocturia. So if, let's say, a patient with Parkinson's disease presented to you with incontinence within 1 year, we should start screening for other secondary causes of Parkinsonism. For instance, multiple system atrophy or other condition like dementia, fronto-temporal dementia. So in MSA, the incontinence usually arises from detrusor overactivity and external sphincter weakness. However, as the disease progresses, incomplete bladder emptying start to manifest. So lower urinary tract symptoms in dementia, incontinence occurs early in normal pressure hydrocephalus, frontotemporal dementia, and diffuse Lewy body disease. Whereas it occurs late in Alzheimer's disease. That means only when the MMSE actually declines significantly in the late stage of Alzheimer's disease, then only patients start to have this urinary incontinence. Okay, patients with frontal lobe damage with frontotemporal dementia, they usually attribute this inappropriate passing urine or even bowel incontinence. So now I summarizes, when you see a patient, what do you do? So I actually try to ask what is the difference between enuresis in a child and urinary incontinence. So enuresis in a child is defined as bedwetting. So nocturnal enuresis refers to nocturnal bedwetting. So in general, newborn and child or children below 1 year old, they still haven't developed full control of the bladder. So they need to wear pampers. But in general, once the baby or once the child has reached the toddler stage, 2 years and above, they start to have some control. Some of them may achieve full bladder control, and they can void when it is correct place. That means you give them the potty and then they will start to void voluntarily. And if, let's say, we try to train the child toileting too early, sometimes it can lead to negative consequences. Let's say a parent always shout at the child when the child wet the bed, or very harsh punishment to the child will develop guilt, and they can attribute neurotic behavior as well as obsessive compulsive behavior when they grow older. Based on Freud's theory, too early toileting can cause obsessive compulsive behavior. Too early toileting or too harsh toilet training can lead to obsessive compulsive behavior. So possible etiology include whether got underlying BPH, any prostate CA, any surgery done, DURBT, bladder, vagina hysterectomy, head injury, spinal cord injury, epilepsy, multiple sclerosis, Parkinson's disease, MSA, dementia, MPH, FTD, or brain tumor, spinal cord injury, TB, transverse myelitis, or MS that involves spinal cord manifestation, or NMOSD, the neuromyelitis optica spectrum. Autonomic nervous system neuropathy also can present with incontinence. The HSAN, hereditary sensory autonomic neuropathy. So when we do the physical examination, try to look for any evidence of spinal bifida, meningo-malingocele, any sacral tuft of hair, and assess the gait for any apraxic gait, Parkinsonian gait, check the sensory level, and check the Beaver sign. So what is meant by Beaver sign? I will explain it in the next slide. So do the parietal examination, check the anal tone for lax anal tone that suggests maybe there is spinal cord involvement, obliteration of the prostate medial sulcus in a man, any irregular surface or hard consistency of prostate, and do the mini mental state examination to check whether patient has dementia. Apraxic gait happen in normal frontal lobe pathology as well as normal pressure hydrocephalus. So investigation, if patient has dementia, do the CT scan brain to look for any cerebral atrophy, any parasagittal meningioma, any brainstem pathology. MRI spine, the level of the spine that you want to scan depends on the sensory level. However, if let's say the sensory level is at T4, but the patient also have hand weakness, finger abduction weakness, then you need to scan higher, because for finger abduction, it is actually C8, T1. So do the lumbar puncture for in cases that you suspect normal pressure hydrocephalus, and check the kidney function, ultrasound pelvis, urodynamic study to assess any post-voiding residual urine, and check the PSA. So this slide illustrates how the Beaver sign is elicited. So you ask the patient to lie down and then raise the head. So under normal condition, the abdominal muscle above the umbilicus and below the umbilicus, they are normal. There is no weakness. But in patients with T10 pathology, that means there is a lesion in the spinal cord T10, not the vertebral level, but the spinal cord. So the abdominal muscle below the umbilicus will be weak. So when the patient raises up the head, as in this diagram, the upper abdominal muscle will become unopposed by the lower abdominal muscle. So the umbilicus will raise up. So this is called Beaver sign. And positive Beaver sign suggests there is a lesion, there is a spinal cord pathology at the T10. Okay. So treatment include lifestyle modifications. Alcohol and caffeine can cause diuresis effect, okay? So, but at the same time, sometimes elderly, they are admitted because of dehydration, especially patients with prostatism. Sometimes because they try to avoid the need to go to the toilet when traveling. So it is important to make sure they are well hydrated. In fact, dehydration is one of the causes for the posterior circulation stroke. So if a patient admitted or presented to casualty with posterior circulation stroke like cerebellar sign or brainstem sign, it's important to rehydrate the patient. And that itself already can improve the stroke outcome. Okay, bladder training, And then pelvic floor Kegels exercise. I will explain about Kegel exercise. And patient can wear the Pampers or wear the pad liner. So what is meant by Kegel or Kegel exercise? Kegel exercise is actually you clench and release the muscles to make the pelvic floor stronger, as in the chart. You lie down and then raise up your pelvis, and then you try to voluntarily contract the pelvic muscles as well as the sphincter. That can make your pelvic floor muscles stronger. And usually postpartum, we will be asked to do this exercise so that we won't have stress incontinence, as well as we won't have any sexual dysfunction. Right. So this slide summarizes what are the medications that we can use for patients who presented with urinary symptoms, either obstructive symptoms or irritative symptoms like urgency, frequency. So one is pelvic floor muscle training, and we can give alpha blocker like terazosin, tamsulosin. In patients with BPH, we can also give 5-alpha reductase inhibitor, finasteride, to shrink the prostate. So antimuscarinic drugs is useful for overactive bladder. Okay, oxybutynin is one of it. You can give TDS or BD dose. So antimuscarinic agents are the first line for overactive bladder and urge incontinence. Okay, the side effects include anticholinergic side effects like dry mouth, blur vision, constipation, and tachycardia. But in elderly, we need to be careful because it can cross the blood-brain barrier and act on the central muscarinic receptors, causing confusion. Another drug is beta-3 receptor agonist mirabegron. Like what is stated, beta-2 agonist usually will cause relaxation of the detrusor smooth muscle, and that can increases the bladder capacity, so can improve the storage symptoms. So in summary, for spastic bladder, you can give anticholinergic and Botox injection. Botox injection will be inject to the detrusor muscle. Okay. For flaccid bladder, you can do suprapubic compression and CBD or intermittent catheterization. For nocturia in MS or nocturnal polyuria, sometimes we can give desmopressin, which is a synthetic vasopressin. How it acts is actually it temporarily reduces the urine production by promoting the fluid reabsorption. However, the side effects include hyponatremia and fluid overload. So if patients have underlying congestive cardiac failure, you need to be cautious. So Botox injection, actually not all the neurologists can do the Botox injection for the bladder, but I know UKM, they provide this service, so we can actually refer to them. And measuring the post-void residual urine is important because if the residual urine exceeds more than 100 cc, it makes the patient at risk of UTI. And UTI itself, if it causes pyelonephritis, it can jeopardize the renal function. So this algorithm suggests when a patient presented to you with urgency and frequency, first you rule out UTI first. Check
Dr. Yo, are you there? Dr. Yo, I think maybe we lost her. Just hold on for a while. Okay, sorry everyone, because there has been a bit of technical glitch. I will share one of the slide. Okay. She will join back later.
Okay, so we can talk about this summary first lah. Okay, so just now I have covered what, who, when, where, why, the 5W and 1H. So below the belt neurology actually include bladder, bowel, and sexual dysfunction. So the bladder can be in the form of urinary retention or urinary incontinence. Bowel symptoms can be either constipation or incontinence. So sexual dysfunction can be due to low libido, erectile dysfunction in men, and frigidity in women. So I have also covered the anatomy of the bladder that includes 3 components: bladder, internal urethral sphincter, and external urethral sphincter. So under parasympathetic stimulation during micturition, the bladder, the detrusor muscle will contract and internal urethral sphincter will relax. If the social situation is appropriate, then our external urethral sphincter also will relax following the somatic control by the pudendal nerve. So now we go to this micturition center. You have pons. Okay, so oh, there is is it okay? Okay, so for suprapontine lesion, that means the lesion is above the pons, either in the frontal lobe or any region of the brain that above the pons. Patient can have predominantly storage problem because there is a overactive bladder, but the sphincter is still normal. But if the lesion is below the pons, but above the sacral, where the thoracic outflow is predominant, then patient can have both storage and voiding problem because they have this detrusor sphincter dyssynergia. There's overactive bladder, at the same time, the sphincter cannot relax. There is overactive sphincter. So sacral outflow pathology, usually patient will have flaccid bladder, underactive detrusor muscle, and it can be further divided into normal sphincter and overactive sphincter. So 2 main types of incontinence are very common, which is stress incontinence and urge incontinence. In fact, overflow incontinence is also common. And some patient may have mixed incontinence. So the treatment includes pelvic muscle exercise, medication like alpha blocker. Now we come to this 11 o'clock position, the chart treatment, alpha blocker, terazosin, and tamsulosin, and 5-alpha reductase inhibitor to shrink the prostate. So treatment of nocturia in MS include desmopressin, beta-3 agonist, and Botox injection. So for PD, if the incontinence occur early, sometimes we need to rule out atypical Parkinsonism like multiple system atrophy. So detrusor sphincter dyssynergia can cause raised intravesical pressures, and that can cause complications like hydroureter, hydronephrosis, and further leading to jeopardized renal function. So in summary, now I will go back to the slide. I will share my slide. Oh, but now cannot. Maybe you can stop sharing. This, okay. So I go to screen. Stop broadcast. So just now, I think you all cannot hear me when I talk about sexual dysfunction, right? Stress is common cause of sexual dysfunction, and we need to relax during sexual intercourse. So if patient had history of sexual trauma, like being raped before, or they can have psychological sympathetic overactivity, and they cannot relax. In fact, when a person have chronically sympathetic overactivity, either due to thyrotoxicosis or due to overwhelming stress in life, they also will have insomnia, cannot relax, cannot sleep, because sleep, you need to relax, then only you can sleep. Okay, so other medical condition like the hypertension, diabetes, hyperlipidemia, that one can cause atherosclerosis and leading to reduced blood flow to the male sexual organ, leading to impotence. Okay, beta blocker is another medication that can reduce sexual performance. Alcohol use, chronic alcoholism can cause peripheral neuropathy, especially autonomic neuropathy, leading to sexual dysfunction. So what about libido, low libido? Low libido can happen due to low testosterone. For female, could be related to hormonal changes following breastfeeding or menopause. When the patient is in the menopause state, there will be reduced vaginal lubrication. So that can cause dyspareunia. There is pain during sexual intercourse, and that can cause shunting or shying away from the sexual intercourse. Other causes include high blood pressure, diabetes that can cause atherosclerosis, relationship problem, or stress, or fatigue. Fatigue is particularly common among young couple with newborn, or if they have twins, then it's even more stressful because both babies crying for milk together. All right. So now we come to cases, okay? But the cases I just want to illustrate, these are the common presentation, and these are the real cases that our neuro clinic have seen before. So 75 years old man presented with forgetfulness, slowness. Can you hear me? Because I'm using iPad, yes. So I actually cannot see the chat box all that yet.
Oh,
later I will, but because I already signed out, so I don't know the question, or maybe we talk about the question first before we discuss about the cases.
So far there has been no question yet being posted.
Oh, all right. Okay.
I'll mute.
Okay. So 75 years old man presented with forgetfulness, slowness, and urge incontinence. He denied prosthetism. On examination, he has mask-like faces with axial and truncal rigidity and upward gaze palsy. Actually, upward gaze palsy can happen even in elderly, normal elderly without PSP. PSP usually is downward gaze more, actually. But this patient, his problem is actually Parkinson plus syndrome. Okay, PSP. So another one is 15-year-old Form 4 student referred by Srimanjo, complaint of acute onset of bilateral lower limb weakness. Okay, actually, if time permits, I will also talk a little bit on approach to weakness, because a lot of incontinence, sometimes they are associated with weakness or paresthesia as well. So she had a fall due to lower limb weakness. So her weakness first, then only had a fall because giving way. So she fall in a sitting down position. There was no loss of consciousness, no head injury. On examination, the upper limb is 4/5 proximally, and hand grip is 5 minus. But lower limb, the power is only 2/5 with breeze reflex. Potassium is normal. Okay, potassium is normal is not important in this case because patient actually has breeze reflex, so it's not. But if patient actually has reduced reflex, potassium, whether potassium is normal or not, is very important in the context of patient with weakness without any sensory complaint. All right. Another case, yesterday only I received the consultation, but the case is actually quite far away in Temolo. So 32-year-old man complained of numbness of both hands and leg for 1 week. Then later he cannot feel the bowel open yesterday. So he was alarmed and was warded. So now this case is still under investigation. So another case is a Chinese man, construction worker, excuse me, had a fall from height 50 years ago. He was a construction worker. So since then, he complained of backache. But past 2 days prior to admission, he complained of intense pain, backache while sleeping. So on admission, actually, both leg is power 0. And there was a reduced sensation from umbilicus downward. So this one is spinal cord. And it's a flaccid, so spinal shock. Lacks anal tone, sensory level at T10. So actually, if you check the Beaver Sign, it will be there. Perianal sensation is reduced, proprioception is there. So this one, you need to do urgent MRI, okay? MRI of the spine and thoracic spine. All right. So another case is 45-year-old lady referred by SP Sungai Petani Hospital, presented with acute flaccid paraplegia associated with urinary retention and lower back ache. So MRI spine show cord swelling, increased density in lower thoracic cord, and cornus medullaris from T11 to L1. So this one, you treat as transverse myelitis, but acute state is flaccid, but later it will become, but because it involves cornus medullaris, sometimes patients still flaccid, but upgoing plantar. So another case is 42-year-old man with underlying HIV and hepatitis C positive miliary TB, presented with urinary frequency and incontinence. And on examination, there is a sensory level at T8, also got CMV retinitis with ketchup, all the features. So our impression is thoracic myelopathy to rule out CMV myelopathy. So MRI mainly to rule out any cord compression. So now we come to medical myelopathy, okay? CMV myelopathy is a medical myelopathy due to infection. All right, so in summary, I've covered the below belt neurology, that bowel, sexual, and urinary, the 5W, who are involved, what is it, what is incontinence, what is enuresis, what is neurogenic bladder, who are affected, multiparous, post-surgery, brain, neurological disorder, dementia, MPH, Parkinsonism. Where is the pathology? Micturition center in the pons, sympathetic, autonomic nervous system, parasympathetic. Why? Okay, the psychological, in patients with fit, actually, when you observe a patient who presented with fit, GTC, you will observe that actually they are like fighting, they are like fighting. So the psychological basis behind this is they are stressed out, they're anxious, and they want to fight, but they dare not fight when they are conscious. So when they had the GTC, they shut down the consciousness and then they fight. And why sometimes they bitten the tongue is because sometimes in life, they wanted to say, they want to voice out their unhappiness, their frustration, but they dare not. And then this incontinence is actually meant, the meaning behind the urinary incontinence and fecal incontinence is they feel shameful. That prior to the fit, whatever that happened makes them feel their ego or their self-esteem is jeopardized. All right. I've also covered the physiology of micturition, types of neurogenic bladder, types of incontinence, approach to urinary incontinence, and algorithm. So this is the summary. Okay. All right. Okay. Do we have time? What is the time now? Okay, 53 only. Okay. I want to cover this more important. I cover this. Okay. So it's important to understand the patient, because disease in our body is related to disease in life. So if you break the word disease, is disease. This is no, is comfortable. That means when a patient feel uneasy with their life, they can develop disease. Okay. So just now I explained why the patient develop it. So now we try to bring back to us why we tend to get flu when we have lack of sleep. Now, sometimes you have so many things, and students will sometimes one after another, they get flu before the exam. Why is it so? And if you send your child, your child to the nursery, beginning also they will get flu. And then you said it's because the nursery got a lot of germs. But the truth is, throughout the year, the nursery also will have a lot of germs. But why during the beginning? During the beginning is because the child is stressful. So now we come back to what does flu means, because your body actually can speak. When you are having runny nose during flu, this runny nose means you are crying for help. So the child whom there is separation anxiety, the child is crying for help. So you have flu. So in general, students get flu because conscious mind, I want to stay up late to study for exam. But subconscious mind, your body want to rest. So your body is crying for help, because before exam, actually a lot of students, including myself, sometimes we feel, hey, there are so many things to read, so many things not yet read. So in general, I will always encourage you all, do not keep all the things. You can save all the PowerPoint, all that, but it's better to learn now than keep, because a lot of times, I mean, based on our experience, there are many things that we keep. If after exam also we haven't gone through that particular thing yet. Okay. So now we come to why we tend to get headache when we attend the full day conference. Most people think it's because of eye strain, and it is partly correct, but actually headache happens when there is a conflict between conscious mind and subconscious mind. So conscious mind, conscious mind, I want to stay I want to stay in the conference to learn more. But subconscious mind, I want to go back to sleep. I want to go to Komta to meet somebody. So there is a conflict, then your body will give you the signal in the form of headache. So let's say the conference is actually public, and male will leave first. Female, usually they are more disciplined person, they stay longer. Okay, now we come to why supervisor like chief, MA, matron, they tend to get neck pain. Why? Because our neck is the structure between the head and the body. So matron, manager, bank manager, they are middle person. So pressure from the top and then the subordinate didn't cooperate, the manager will feel trapped. So that stress in life will manifest in the form of neck pain. And what is the function of neck? Is to bend, to turn. So in life, when we feel stressful, that we need to bend our principle, bend our ego, bend our personality, which we don't want, but we are being forced to, because then this unpleasant emotion, the upset, can cause the pain. In fact, all types of pain, all types of inflammation is due to suppressed emotion, anger. So this slide summarizes, can our body speak? Yes, the body can speak in a very unique manner. Different symptoms got different meaning. Same like jaundice means hepatobiliary dysfunction, but headache means there is a conflict between conscious mind and subconscious mind. So our father of modern medicine, William Osler, father of medicine is actually Hippocrates, but father of modern medicine is William Osler, the Canadian physician, the late Canadian physician. He said the organ weeps, the tears, the eyes refuse to shake. So what does that mean? That means when faced with adversity, if we suppress our emotions and didn't cry, this energy becomes trapped in the organ, and the related organ will become dysfunction, and our body will manifest the symptoms. So symptoms are just the metaphor. Physical symptoms ranging from headache, numbness, tinnitus, or incontinence are just a manifestation of our disturbed inner well-being. So this is the last slide that I will explain. So this slide summarizes disease is due to disease in life. Disease in our body is due to uneasy in our life. And when we are uneasy, we will have emotions. And what is emotion? Emotion is energy in motion. So first we have the stress, and then we start to have the symptoms. If you scan that time, everything is normal. Blood test is also normal. But if the stress perpetuates, the symptoms will get worse. But if you can reverse the stress, then everything will be normal. But if the stress perpetuates, one fine day, you repeat the scan, now the scan show no specific changes, what matter changes or degenerative changes. If you still didn't tackle the stress and you feel very frustrated with life, then your body will start to go into the degenerative mode. And one fine day, you can develop stroke or heart attack. So stroke or heart attack happen when the person is having root block in life, because vessel block in the form of heart attack or stroke, either vessel block in the heart or vessel block in the brain, that suggests root block in life. So I give simple examples. Sometimes we see a CEO, CEO, can you hear me? Sorry. Can you hear me?
Yes.
Okay. So CEO in life, let's say share market crash, business failure. Okay. Suddenly, heart attack, stroke. Why? Because there is root block in their life. They are facing something that they don't know how to move forward. So just now we actually started a little bit late. Maybe I just explain this slide to close. So all disease originate in mind. There is a link between the stress and the body. So a person becomes sick when emotionally they are disturbed or in distress. So loneliness, frustration at work, anger about a past trauma, financial distress or fear can result in illness. So this patient has pelvic pain whenever the boss came to the office. So she went to see many doctors. The gynecologist diagnosed her as having endometriosis and suggests an operation, and urologist consult. The urologist did the cystoscope and diagnosed her with interstitial cystitis, but suggested her to see a gastroenterologist just to be certain. So the gastroenterologist did the OGDS and colonoscopy and labeled her as having irritable bowel syndrome. Okay, yet nobody talked to her about the fact that her pain only comes when her boss is in the room. Nobody suggests that perhaps the stress of her job and her dysfunctional relationship with her boss is manifesting as physical symptom because of repetitive stress response in the body. Perhaps rather than drugs or surgery, what she needs is a new job so that she can heal her negative thoughts, allowing her body to repair itself. Even in multiple sclerosis also, there are examples that there are papers that talk about stressful life event will trigger the exacerbation of the relapse of the MS. All right, even Saint Gonzalez also said heart attack or even AF happen following loss of loved one. And this one I can tell because some of my patients, we make this poster in the clinic, and the relative or the patient will see this. Excuse me. So stressful event can present with acute cardiac arrhythmias or even heart attack following the loss of loved ones. Then in casualty, you will see a lot of accidents. So accidents are actually expression of anger. Sometimes we see in a movie or real life, there is a separation, there is the person broke off in the relationship and then very angry, frustrated, agitated, go out and then met with an accident. Then after that, totally cannot remember, amnesia, or they become paralyzed. Why? It's because they are very upset and they don't want to remember the painful memory. This is a defense mechanism, but at the same time, they need time to heal their emotional wound, and they present it as a physical wound so that they have the time to recover. All right, I think we'll end now. Thank you. No question, huh?
I thank you very much, Dr. Yo, for your extensive talk, not just about the below the belt neurology, but also about the subconscious mind. All right. Do we have any questions coming from the participants? I don't see anyone typing inside the chat box. Maybe you want to unmute yourself and ask the speaker.
Could I hear me?
I will share later the two PDF which was being shared by Dr. Yo to me. I will put in later inside the chat box again, because when I shared earlier, the participants' numbers was already just about like 6 to 7 of them. So yeah, anyone? Any burning questions? I have one question for you, Dr. Yo.
Yes.
Yeah, actually, I was wondering, well, the in a way, you're supposed to be relaxed for you to basically initiate micturition, correct? But why would in a patient, in anyone that has like maybe they are frightened, like they have seen a ghost, for example, they will pee in their hands. So it's like it's a sympathetic overdrive. But the patient pee, aren't you supposed to be holding your urine? So why do they lost their sense of taking care of the voluntary control of the bladder, or I mean the sphincter, or how?
Yes. You raise a very good question. It's actually the pathology is in the somatic control. It's no longer actually during the fear, all that, there is sympathetic overactivity, correct? So theoretically, your internal sphincter will contract, correct? So you won't have the incontinence. But there is also this somatic that come in. Somatic control. Like for instance, when you are anxious, when you are very anxious about something, all the information cannot register to your brain, correct?
Yes.
Correct. You notice like let's say there is something stressful, then after that you forget during that period where do you save the thing.
Yeah.
So I give you another example to explain this. Like for instance, excuse me, I give you the scenario. This this is a real case. One of the doctor's husband complained of since many years ago, I think since small already cannot sleep one, always cannot sleep. So I actually use the memory recall to help him, and he remember one incident. He sustained injury and then need to be sent to the hospital. So in the journey, the sister always keep on telling her, don't fall asleep, because I think it's a head injury or what. So during that time, he only remember this. So he cannot relax. He always cannot, because there was this one already go into direct to the subconscious mind, and your subconscious mind is the one that control your autonomic nervous system. Correct?
Okay.
Correct or not? Like for instance, subconscious mind actually control 93%, you know. The conscious mind is only 7%. So the subconscious mind, like before exam, conscious mind, I want to study, stay up late, but subconscious mind want to sleep. So subconscious mind always win, because it controls 93%, the power. Like, so when you have the flu virus make you sleepy. Whatever you take for cough and runny nose also make you sleepy. If you sleep within 1 day, you get better. But most of us don't understand this. So we continue to burn the midnight oil, and then we get the secondary bacterial infection, and then cough. That is in the distress, all that. So it's very important we understand when you are in a very stressful state, that time your subconscious mind will take over. Oh, okay. And that no more the conscious mind control, like REM sleep behavior disorder. The conscious mind, they I cannot retaliate, I must follow orders, I cannot answer back is not good. But when they fall asleep, no more control from the conscious mind, all this behavior come out. They fight, they beat, they scold in the dream, they scream in the dream. That is REM sleep behavior disorder. All right. Okay, thank you. I scared the second speaker, Dr. Farid. Okay.
Yeah. Okay. Do we have any more question? If we do not have any more question, I think I think it is a very challenging topic. We talk about below the belt neurologist, because I've never heard any neurologist talking about this. But I came through when I was I registered myself for the Harvard. Maybe it is like not so pertaining to emergency, the non-neurologist, but I think it's kind of important, because sometimes we are cracking our head. We can't really find what's the problem with the patient. So thank you so much for giving basically a walkthrough of below the belt neurology, and thank you very much, Dr. Yo, again for sharing with us the interesting part of the subconscious mind. So without further ado, I would like to invite the next speaker, but before